we are about ready to have our panel discussion. As mentioned, please feel free to ask your questions at any time. Some of you already asked a few questions. We will address these and other questions at the end of the panel discussion. To lead our panel discussion, I would like to introduce Terrence Sullivan. Terry has had many senior positions in healthcare throughout his time. Many of you will know Terry from when he led Cancer Care Ontario. And it is my honor to turn the session over to Terry Sullivan. Terry, it's all yours.
Thank you very much, Matt, and thank you very much, Kim, for that splendid overview, precisely on time. So let's get started. I think we have Harpreet Bajaj as the initial speaker, and to be brief, Harpreet, I'll run through each of the speakers in one go, and then we'll come back to Harpreet if that's all right. Harpreet is an endocrinologist who leads late phase research at LMC Brampton, Healthcare Brampton. He has affiliations with McMaster and Mount Sinai. He's very involved in the Canadian Diabetes Prevention Program supported by the Public Health Agency of Canada, and founder of Stop Diabetes Foundation, a charity working to reduce diabetes in Brampton. I'll move next to David Kaplan. These are the sequence in which the speakers will talk. David Kaplan is the primary care quality lead at Ontario Health. He's a family physician who practices comprehensive family medicine, and he's vice chair of the Medical Advisory Committee at North York General Hospital, and associate professor and member of the Joint Center for Bioethics at U of T. Our third speaker following is Karen Cross, fellow Newfoundlander, I might add. Karen is an MD PhD assistant professor at University of Toronto and plastic and reconstructive surgeon at St. Mike's Unity Healthcare, surgeon entrepreneur, co-founder of Mimosa Diagnostics, and medical lead for the new digital health wound program at St. Michael's, and professor of surgery at the University of Toronto. Kathy Whiteside is a very well-known nephrologist. She has been very actively involved as the former dean of medicine at the University of Toronto. She's been widely decorated for her honors and her contributions, including the Order of Canada. She remains extremely busy on a range of commitments, which I could not properly enumerate as there's too many. But the one that is most close to our interests here is the one in which she is providing outstanding leadership in the creation of Diabetes Action Canada and all of our colleagues, the CIHR National Support Network in Diabetes and Related Complications. So those are our speakers for this morning, and I think we'll, without further ado, jump right in with Harpreet.
Hi, good morning, everyone, and thank you. Thank you for this opportunity to talk about what I want to talk, which is around diabetes prevention, screening, and about education. I'm sharing my screen. Can you confirm that it is okay? It is being shared?
Yes, indeed.
Okay, thank you, Terry. And thank you for that introduction, Terry, and look forward to the panel discussion and learning from all the other panelists as well. So I'm a community endocrinologist, but I'll take off that hat, or turban, I should say, and put on a public health hat for this part. I'll start off with where Kim led us in this keynote speech with Diabetes 360. I'm going to focus on the top half of it, so the top 180 degrees, if you will, of this 360 degrees. Especially around the 90 degrees that concerns with prevention of type 2 diabetes. And then the other 90 degrees around Canadians being aware of their diabetes status, which deals with screening as well as education around that screening as well. So I'll start off with this picture of an iceberg. And of course, diabetes is a pandemic that is growing. Numbers may vary from year to year, but around 11 to 12% of Canadians have been diagnosed with type 2 diabetes at this time, which is only the tip of the iceberg, because beneath the water level is people who are at high risk for developing type 2 diabetes in the future, which includes a large chunk of people who have this entity called prediabetes. Some people call it borderline diabetes or a touch of diabetes. There are different terms. Some of them may be correct or not as well. So prediabetes, there's a larger number of people in Canada who live with this condition than actually with diabetes. And research points out that 70% or more of these people with prediabetes will actually go on to develop type 2 diabetes over time. And in addition to having prediabetes, there are actually other health conditions or history things that are considered high risk for developing type 2 diabetes. For example, a family history of type 2 diabetes or certain ethnicities and BMIs as well. So what can we do about diabetes prevention is what I'm going to discuss. Of course, it's important to talk about diabetes treatments and equalities of treatment and providing care for people with type 2 diabetes. But to slow the epidemic in the future, prevention is important. And what does research tell us about prevention? Is it even possible? So this is the only data slide that I'm going to share, which is from the diabetes prevention program down south of the border in the US. They do great research, at least they used to. More than 3,000 people participated in this program. All people included had pre-diabetes. And there were two interventions that were laid out in this program, which was compared to placebo, placebo being standard of care. Okay, you have pre-diabetes, tell the participant and tell them to try and change their lifestyle on their own or do something about it. The other treatment groups included metformin, which is a diabetes treatment, which reduced the development of diabetes during the trial by about 30%. But which intervention won out was actually the lifestyle intervention. And it was intensive lifestyle intervention over a 1-year time period, not just a one-time dietitian appointment or something. Over a 1 year, a weekly contact with a health coach, individualized health coach for the first 3 months. And then monthly after that, from month 4 to month 12 was what was the intervention. And that reduced the development of type 2 diabetes by 60%, so about double of what metformin did. And further long-term data, 15, 20-year data from this study and other studies that have been done, similar studies that have been done around the globe, suggest that diabetes prevention happens, and also possibly reducing other complications, including cardiovascular disease and longevity as well. So other wellness is fostered with this intervention as well. So what's the problem? We have the data. Why don't we intervene with this data and provide this intensive lifestyle modification to everyone who has prediabetes so that we can slow the epidemic? There are many-fold problems with that. One problem is, of course, resources and costs, as well as getting interactions or engagement from people on a continuous basis for 1 year on an individual level. Also, now with the COVID posing additional challenges around congregation or meeting people as well. So what's the solution? Solution is digital. And we have now, as a pilot, a Canadian diabetes prevention program, which is taking the same kind of format from the diabetes prevention program down in the US and putting it all digitally online and over the phone. It's a pilot program that is taking in over 2,000 participants until the end of 2021. It's a 1-year program, all online and over the phone, with individual health coaching being provided. It's at no cost to the participant, and it's a 12-month program. It is funded in majority by the Public Health Agency of Canada, and LMC and Diabetes Canada and are bringing this program together. So who is eligible for this program in Canada at this time is at the bottom. which is people with pre-diabetes confirmed on a blood test or otherwise deemed to be high risk on a risk calculator. So how do we get that though, right? So that brings me to screening, which is another challenge that exists in Ontario as well as in Canada. So there are guidelines around screening and who to screen and when to screen. This is from the 2018 guidelines from the Diabetes Canada Clinical Practice Guidelines, that anybody above 40 years of age in Canada should be screened at least every 3 years. And even if people are less than 40 years, but they meet other high-risk criteria, they should be screened as well. So screening includes blood testing, of course, and then we can categorize people into whether they have normal glucose or whether they're at risk for diabetes, which is fasting glucose between 5.6 to 6, A1C 5.5 to 5.9, or prediabetes. I've given the definition there, or even diabetes. So screening is the tool that we find out where people are, and then we can guide them, educate them accordingly as well. But it's important to screen. Now, the truth of the matter is, and the fact is that screening does not happen as per the guidelines. In fact, even to date, most people with diabetes, not just pre-diabetes, but diabetes goes undiagnosed for over 10 years on an average. Even in Canada in today's date. And so screening is not happening. That's another challenge. And even if screening happens, the next challenge that comes is the proper education and information sharing around type 2 diabetes. So a simple question, what is type 2 diabetes? There are many definitions which can be complicated and stuff like that. But a simple definition from a simple medicine textbook, Harrison's, by the way, Anthony Fauci is one of the authors on this textbook as well, and he's a great scientist. Of course, some people may think differently. Diabetes is a chronic and a progressive disease, and that's the simple definition of type 2 diabetes. The problem, though, is medical or healthcare providers know this definition. People with diabetes, type 2 diabetes, may not know this definition until it's too late. They don't get to a diabetes education center to know that this is a permanent condition or a condition that gets worse over time. They don't even know that, many of them. So proper education at diagnosis is another key challenge that exists in this province as well as countrywide as well. As a result of that, what people get either through Dr. Google or from their neighbor or their colleague is the wrong information, which may not add up the right way when it comes to preventing complications in the long term. So that's my last slide. In summary, what I've hopefully been able to get through in this short time period is that Ontario and Canada is facing this epidemic that is growing. And we need to focus on the diabetes part, the care part, but also focus on prevention of that type 2 diabetes by focusing on diabetes prevention, like the Canadian Diabetes Prevention Program in people with prediabetes or high risk. And then screening at the right time with the schedule that has been provided by Diabetes Canada guidelines. And then once they have that information, then do something about it, which is the right education. So that's all I had. I look forward to the panel discussion at the end of this as well. Back to you, Terry.
Thank you so very much, Harpreet. That was an excellent overview from a well-respected endocrinologist. Let's move right forward now to David Kaplan, Primary Care Quality Lead at Ontario Health. And I'm sure we'll have a range of questions about specialty care and primary care as we get into the discussion a little further along. So, David?
Thanks, Terry. Appreciate it. Everybody can hear me fine, I hope. So I want to thank, first of all, Longwoods for giving me the opportunity this morning to provide a bit of a primary care family medicine perspective at this HealthcareRounds event on diabetes. I don't have slides, but I will be talking this morning. And again, if there's anything that comes up in the chat, I'm happy to address it. We've already heard this morning about the burden of diabetes on our patients, our healthcare system, and our economy. Aside from experience as a family physician for nearly 2 decades, a health services researcher and a healthcare leader, I understand the burden of diabetes as a family member. My father was a lifelong smoker. He lived with diabetes for a bit over 15 years before dying of metastatic lung cancer, very young at the age of 61. And believe me, even well before both becoming healthcare providers ourselves, my sister and I tried to help him stop smoking and eat healthy and become active. And none of those things are easy. But I do think that developing a value-based outcomes model for a provincial diabetes program using standardized models of care similar to what we've done in the cancer system could profoundly impact people like my father who live with diabetes. But my main message to everybody this morning is that the treatment of diabetes cannot be our sole focus looking forward. The increasing incidence of diabetes in this province has been and will continue to be a failure of our integrated public health strategy. And unless we make changes to the way that we educate and support our children and our young people, and it's not about preventing disease, specifically diabetes, but it's actually about giving them the tools to lead healthy lifestyles, because we know there's so many common pathways to poor health. And it's not about medicine. It's really about what is our moral obligation to our children and to our society. Our government's built on existing investments in prevention and care improvements on diabetes service by providing clinicians with the data they need to target their care. In the past, the family medicine specific interventions have included ensuring that all patients with diabetes have access to a primary healthcare provider in the province, trying to ensure that 80% of patients or people living with diabetes receive all 3 diabetes tests, as many of you are familiar with, within the recommended guideline period for optimum diabetes management. And we know that getting that data has been very difficult for a lot of providers, especially primary care providers. More recently, Health Quality Ontario, where I work, and now Ontario Health, we've been providing about half of the family physicians in the province with personalized My Practice reports, which include diabetes indicators, so they can see their care patterns in relationship to their peers and focus on the areas of their practice where they're not doing well. So they could be doing extremely well in cancer screening, but they may not be doing well in diabetes care. And it does allow them to figure out where do they need to focus their quality improvement energy. Moreover, in our My Practice reports, we provide suggestions and resources alongside their data, so they can spend less time looking for and thinking about solutions that may already exist in the province and more time helping their patients. However, what's waiting for us over the next decade, as we know, is a tsunami of patients who at the moment look like they're going to be developing diabetes. I would argue that many of these future diagnoses are preventable. The combination of a car-friendly culture and popular sedentary activities like watching Netflix or playing video games have made it unsurprising to me that over 51% of Ontarians are physically inactive, and then more than 52% are obese or overweight. And while we've done so well with the treatment of diabetes in the last 15 years, our age-adjusted mortality has fallen by 25%. The prevalence of diabetes continues to increase, and the rate of that increase has been steeper in younger Ontarians, aged 20 to 49. And therefore, as I've already suggested, I think we need to focus part of our future investments on prevention strategies that have been shown to work. As we've heard, diabetes prevention programs have shown that people at risk for developing diabetes can either prevent or delay the onset of their diabetes by up to 58% by losing a modest amount of weight through diet and exercise. It's better than any pill we could ever give them. But as a family physician, I often focus my interventions upstream. Over 10 years ago, the CMAJ, the Canadian Medical Association Journal, reported that the average Canadian child spends 3 to 5 hours a day sitting in front of a TV or computer screen. The study also showed that in the last 15 years, the rate or the incidence of obesity has grown by more than 50%. Over 25% of Canadians who are under age 17 are overweight. And while the Canadian Physical Activity Guide advises that children should aim for 90 minutes of physical activity a day, the most recent report in 2018 has found that only 30% of our country's children and youth are even getting 1 hour of physical activity a day. And therefore, this morning, I would suggest that we need to make the following 5 action items that cut across not just the Ministry of Health, but all of the ministries in Ontario in order to make the following changes. 1, fully fund diabetes prevention programs in our Ontario health teams, not just digital diabetes prevention programs. Our OHTs can be given the data to identify patients at risk for developing diabetes and proactively reach out to them. 2, children's work is play. We must increase physical activity through unstructured activity and access to play equipment. And yes, this may come at the expense of grade 3 math test scores. Why is health class only required till the end of grade 9? I can't explain that. 3, teach healthy eating. We already have a model for this in the early years centers that are rolled out all across the province. We need to give parents and children practical, healthy eating advice, meal planning, importantly, culturally sensitive meal planning and portion sizes. School-age children are actually our conduit into the homes of our province. And lastly, parents need to be the role models for their children, not the school. I tell my parents in my practice that they need to be role models for an active lifestyle for their children. And this involves limiting television and computer time to less than 2 hours a day to reduce a child's sedentary time. We need to reduce our recreational screen time, especially in front of our children. This is really about changing a whole family's lifestyle. These are not easy interventions, but they're interventions that happen just like we intervene in well baby care to ensure that children are in the right automobile car seats or put to sleep properly. We have a unique opportunity through our longitudinal relationship with patients to help them change their lifestyle, but we need the tools publicly funded to support that. We've made great stride in the treatment of diabetes and in the prevention of diabetes complications. I think models like Diabetes 360 have the potential to spread and scale the best treatments across the province and the country. But my message to each of you this morning is that we need to focus on prevention. Preventing this disease and the physical, social, and financial implications of this disease is doable. It is the quintessential shift from disease treatment to disease prevention. We owe it to ourselves, we owe it to our families, and we owe it to our children. Thanks.
Thank you so very much, David. That was spectacular. So I know we're going to come back to, in particular, the role of primary care in diabetes, but let's move forward now with Karen. Welcome. The floor is yours.
Okay. I feel like, David, we should stand up and clap for you. That really resonated with me, especially with a little toddler, 3-year-old at home. And I think probably some of the messages I am glad to hear from my own primary care physician. So thank you very much for everything that you do. I'm going to sort of deviate a little bit because personally for me, if this group could prevent diabetes and I would never have to see another diabetic lower extremity, I'd be happy to be out of work. I can tell you right now, currently, and I'll just make this big. Can everyone see my screen? Hopefully, is that we were in a global tsunami before COVID. I can tell you right now, we're amputating limbs almost every day. It's not just like portions of their feet. We're doing more above knee amputations, which is really horrible for long-term outcome for walking and ambulation. This has been the worst I have ever seen in my entire career in terms of severity of the disease. And so just that 6 to 8 week delay on a lockdown of a lack of preventative care is changing everything that we're seeing now. And I think a lot of patients are very afraid to come to the hospital for help, which is where a lot of the wound care and sort of that end stage care occurs. So it's actually horrible. It's completely horrendous right now. So I really want to focus and hone in on the lower extremity complications. This is where I am a key opinion leader. It's also what I do in my day-to-day practice. We've talked a lot about the statistics, and what I want to recommend if anyone is on social media or they have an opportunity to promote is Wounds Canada is trying to have a campaign prior to World Diabetes Day about saving the 4. So we know that 4 out of 5 amputations are preventable. So if you have the opportunity today, we want you to take a picture of yourself, 4 fingers up, post it on all of your social media platforms, because we know that we can prevent people from getting to that point of that amputation. The other piece that I think people don't understand about the lower extremity is currently right now in the world, every 20 seconds, someone's limb is being amputated secondary to diabetes. This is very personal for me. I actually lost my own family member in Newfoundland to a diabetic lower extremity during COVID. So we spent 15 years trying to keep this limb healthy and attached. It didn't end up happening that way, and then they succumbed to complications associated with that. 30% of people in the first year after amputation, they succumb to the injury. So it's a mortality rate of sort of the 30%. That's more than the lifetime risk of dying from cancers. And just think about how much money we raise to try to combat solutions to treat cancer, but how much money do we raise for the diabetic lower extremity? How much attention is being paid to risk profiling these patients or preventing these complications from happening? And I can tell you not very much. Let's get into what's the problem. And I think if you're going to take something away from what I have to say today, it's really this slide. The first thing is around foot checking practices. So unless you're a key opinion leader or you're someone who's looking at feet all the time, I can tell you these foot checking practices are relatively inadequate. For the most part, only 1 of 4 criteria are evaluated. It's very rarely documented how well the screening occurred, and almost never is there a risk profile associated with that foot screen. So it might say foot screen performed, but there's no risk profile associated with that. That's like telling someone they had cancer and saying, hey, we have some treatments. I think we'll just give you this treatment. If you don't have risk profile, you don't know how to properly treat the patient. So foot checking practices are absolutely inadequate, both by the patient, and you can't expect them to know 20 years of what I know or their loved one. And the same is for healthcare providers. Time is tissue. If at that time when they get that first injury to their foot, if they're not seen within 6 weeks of that injury, and I mean seen by someone who knows what to do, that delay in outcome really results in poor outcomes. The average time to referral to a clinic, something like myself, is 26 weeks. And so this is a well-established clinic. I would imagine those times are much longer if we truly could look at the data. So 26 weeks when really we need to see them within 6. So that's a concept called time is tissue. So it's a surgery concept. There's communication chaos. I can't tell you how many text messages I get. I'll probably get a few even during this talk. What would you do with this? Where should I send this patient? What should I do? There's a lot of chaos on how the patients move through the system. And also even just in the experience of the person seeing the patient. So it does delay a lot of our treatment. And then finally, as I said at the beginning of this talk, the pandemic has absolutely amplified these problems, and they're not going to go away, and they're only snowballing and becoming worse. What does risk stratification look like? Well, this is the screen that's supposed to be done in Canada. It gives you a risk profile, and each category of risk then has a series of treatment line items or best practice guidelines for which your healthcare provider should follow. A lot of times this is very labor intensive, so it doesn't get performed. And as I said before, 2/3 of physicians actually don't recognize the signs of diabetes related foot problems. And I'm not talking about, like small organizations or non-academic organizations not recognizing. I'm talking about even specialists who specialize in diabetes do not know how to recognize diabetes related foot complications. So it's not a blame game here. I'm just telling you the information is that you need a foot expert truly to be able to do this well. If you miss that diagnosis, it results in high rates of morbidity and mortality, which I think is intuitive. What does that really translate into? Well, if you don't risk profile, you're not actually treating the patient appropriately. If you do delay their treatment, that clearly results in poor outcomes, higher what we call Texas grades. Those Texas grades then result in those amputations. There's a lot of inequality in access. I'm actually from Newfoundland. My family member was actually in rural Newfoundland. we know that people in non-urban centers, so in rural locations, that could be easily 100 kilometers outside a city, are 2 to 3 times more likely to have amputation. And most of it is related to access of care. So it's back to that time as tissue delay in seeing someone like myself. And then finally, this is costing us millions of dollars. So if you look at the cost to the healthcare system, there was a Gemini study recently performed of Unity Health, where they showed that the diabetic lower extremity, so yes, the diabetic lower extremity was the #1 most expensive condition to treat. This is also true in the US. We're spending a lot of money to treat this problem. The money is being spent in ulcers as well as in amputations. So we need to prevent both of those things from occurring, as well as if you get an ulcer, you have a diabetic foot ulcer, we need to keep people in remission. So remission means healed. Finally, how are we actually going to see the number of patients that are across our country and the increasing numbers we just heard both from Harpreet and David? And the reality is there's no way that as one person at St. Michael's Hospital, I can see the hundreds of thousands of people that need to be seen, which means we truly need a digital health strategy. So I'm a firm believer, especially with my new role as the digital lead at Unity Health, that we need to improve the accuracy and efficiency. So this risk profiling needs to be done either by taking a picture and giving that non-expert, like my expert vision or expert vision, so those non-experts become experts. We need to communicate better. So we need to have communication platforms where we're all talking the same language and we can create care plans for these patients. We need to be able to monitor the progression of disease. So we need to know when they're moving from one risk profile to the next risk profile. So we need some sort of way to keep monitoring them afterwards. Thinking back to cancer, if you have a diagnosis of cancer, you were routinely followed to see if your risk profile changes. And then finally, we need to remove barriers. So we need to start addressing these inequalities that exist within the healthcare system as it relates to the diabetic lower extremity. That's my brief, opinion and view on the subject. So thank you very much for the opportunity, and back to you, Terrence.
Thank you very much, Karen. That was an excellent and clear presentation focusing on these challenges in foot extremity problems. So let's move on here. We're actually doing very nicely on time. And our last speaker is Kathy Whiteside. And Kathy, the floor is yours.
Thanks, Terry. And Matt, I think you're going to put up my talk, please. So thanks, Terry, and to the organizers for the opportunity to share with you a model of integrated virtual care for complex chronic disease. And a few weeks ago, Diabetes Action Canada partnered with the Ontario Spore Support Unit to present this model at a roundtable that focused on comprehensive virtual care for persons with diabetes. And I have permission from Dr. Peter Selby, an investigator in our network, and the lead for the Smoking Treatment for Ontario Patients, or STOP program at CAMH, to present the following model of virtual care. The report of our roundtable proceedings has been prepared by the Sport Evidence Alliance and will be available on the Diabetes Action Canada website. Next slide, please. The STOP program has evolved over the past decade as one of Canada's most successful virtual treatment and prevention programs. Patients are referred by their primary care or other health providers and engage with the program through a secure online portal system. You can see the extent of the operational sites across Ontario and uptake by over 330 family healthcare teams, community health centers, nurse practitioner-led clinics, and addiction agencies with approximately 27,000 referrals per year. When patients are referred, they're assigned a care manager who works directly with the patient to understand their key health, social, and environmental challenges, including the effects of alcohol use, mood and stress disorders, and other chronic disease. To assist with addressing these challenges, referral to members of a multidisciplinary team enables each patient to receive customized precision treatment. The care manager communicates directly with the patient's regional primary care provider and, as necessary, local social services to enable continuity of treatment and prevention. And this virtual program is highly regarded by patients and widely accepted by health professionals, particularly primary care physicians, as a valued and effective service. Next slide. The STOP program is a great example of technology-enabled collaborative care that incorporates education and enhanced self-management. This model requires identification of the person at risk, who is then engaged in an integrated program where a care path is co-designed with the patient to precisely address their health and wellness challenges. Key elements include systematic follow-up for treatment adjustment, effective communication within the circle of care, and program oversight for continued quality improvement. The addition of technology to establish virtual collaborative care has huge advantages by reducing the need for face-to-face visits, allowing triage before specialist referral, providing support outside physician visits, and, importantly, enabling measure-based care and data collection. Next slide. This model of managed collaborative care is necessary to address the complex needs of persons with diabetes and many accompanying chronic conditions such as heart and kidney failure, peripheral vascular disease, and foot ulcers that contribute to the adverse outcomes described by Kim and, as you've just heard, by Dr. Cross. Timely communication with a virtual team, as well as with the local care provider, and coordination with community services to address the social determinants of health are critical for optimizing quality outcomes and reducing health costs. The COVID experience has highlighted the urgent need to establish technology-enabled virtual care for persons with complex care needs and, importantly, for their healthcare providers. Identifying those individuals with diabetes at highest risk for adverse outcomes and directing limited healthcare resource to addressing their needs are critically important for implementing the Digital First for Health strategy in Ontario. Next slide. Recognizing that identifying those persons with diabetes at highest risk is a barrier, Diabetes Action Canada has established the first national diabetes repository of primary care EMR data in collaboration with the Canadian Primary Care Sentinel Surveillance Network. We now have over 123,000 complete data records for persons with diabetes and an equal number of age-matched controls, the largest group from Ontario. Using algorithms, our investigators can separate who has type 1 and type 2 diabetes, and by linking to provincial administrative data, we are developing the risk calculators based on social and other determinants to identify those at highest risk. We are now seeking to establish virtual care diabetes demonstration projects in collaboration with Ontario health teams using our rich data source and analytics. In sum, the use of technology-enabled virtual collaborative care is now emerging as a solution for addressing the unmet needs of persons with diabetes and complex chronic conditions. Co-designing, implementing, and evaluating these models will be the next step in creating the learning health system we all envision as the future for healthcare in Canada. Thanks very much.
Thank you very much. That was tremendous. I think we're going to ask for a word from Kim in terms of a summary or reflection.
Sorry about that, Terry. Okay, there I am. I think that as I've been listening to the remarks that the others have made, I have felt, proud of the Diabetes 360 framework, and even more convinced that it, as a comprehensive, evidence-based, data-informed solution, it is the right one for us in Ontario and in Canada. And I confess I feel a bit sad, you know, as I sit here as a Canadian affected by diabetes. I have lost everyone. I had family members and close friends that had diabetes when I was diagnosed, and they have all died in the intervening years of the complications of the disease. We're going to be celebrating on Saturday World Diabetes Day. We're preparing to celebrate 2021, and the state of things is really even bleaker than I think we sometimes realize. And so I'm left feeling a bit astonished at how we find ourselves in this situation. We benefit in Canada from such excellent care for conditions like cancer, and thank goodness for that. It's time we up our game. And so I'm so glad to be part of this conversation today and look forward to a discussion among panelists so that we can really chart a path to rolling up our sleeves and fixing this issue for once and for all.
Thank you. Thank you very much, Karen. That was excellent.